Greetings to all. So today we are discussing Introduction to Removal Partial Dentures. Myself, Dr. Sourabh Khandelwal. So first we see the branches of prosthodontics. So basically there are prosthodontics divided into three branches: removal prosthodontics, fixed prosthodontics, maxillofacial prosthodontics. Then the removal prosthodontics is further divided into two: complete denture and removal partial dentures. Then this RPT is also divided into two, that is cast partial denture and acrylic partial dentures. Then fixed prosthodontics is divided into like two more branches, that is fixed partial dentures and implants. And the third branch is maxillofacial prosthodontics. So why is the necessary to replace the missing teeth? So as you can see in the picture, if the only single tooth is missing, like let's say 3/6 is missing, so what are the consequences that can occur in due course of time? So first is the opposing teeth can get supraerupt, and the adjacent teeth, like let's say if 3/6 is missing, 4/6 is missing, so 4/5 and 4/6 can tilt themselves to accommodate the missing space. And the as you can see in the picture also, like with the help of the arrows, each all the three teeth try to accommodate the space. So as to discuss to maintain the function and the prevention of migration of adjacent tooth, prevention of supraeruption of opposing tooth, restore the aesthetics of patient to reduce the psychological effect of loss of tooth in the patient. So now what is removal partial dentures? So according to GPT 8, it is the branch of prosthodontics concerned with the replacement of the teeth and contiguous structures for edentulous or partially edentulous patients by artificial substitutes that are readily removable from the mouth. Then what are the indications of RPD? So the following statements to be considered before planning any treatment for a patient. So there is one scientist, Muller-Dieven, who stated that the preservation of that which remains is of utmost importance and not the meticulous replacement of that which has been lost. So first indication is the length of edentulous span. RPD is preferred for long edentulous span ridges. There we will not go for the fixed partial treatment. Then the distal extension situations where fixed partial denture is not possible because the posterior abutment is not there. So for in that case, either we have to go for a removal partial denture, or if the adequate bone is available, the adequate width and height of the bone is available, then we can think of implant treatment. Then H factor, where FPD is contraindicated, that is young under 17 years who have large pulp chambers and lack of clinical crown lens. And advanced age, where FPD is contraindicated due to reduced life expectancy and frequently failing systemic health. And one more thing, even implants are not possible because if we want to do an implant in such cases, minimum age is 18 years. So implant is also not possible. So then we have to go for a removal partial denture treatment. Then, if there is a weak abutment teeth, poor periodontal support, which contraindicates FPD, if there is no need for cross-arch stabilization, if there is excessive loss of residual alveolar ridge due to trauma or resorption, if we have to replace the teeth immediately, if you have to provide a superior aesthetics compared to FPD, if patient is desiring the treatment because of any economic concerns or anything, like many a times patient does not go for a extensive treatment like implants or FPD. They want to go for a simpler treatments like RPDs. So that we'll consider. Then last is the socio-economic status of the patient. If patient cannot afford such treatments like FPD or implants, then we have to go for a removal partial denture, which is not that much costly to the patient. Then contraindications of removal partial dentures are: if the patient is unable to maintain his hygiene, if the patient is having a poor neuromuscular control, if the patient is physically or mentally handicapped, then we have to contraindicate this removal partial dentures. As we can see, if patient is mentally ill, so many a times he can swallow the removal partial dentures, but it is we have to there is certain path of removal and path of placement of the RPDs. So it is very challenging for a handicap or a mentally challenged patient to wear a removal partial denture, and there are also chances of swallowing it. So it is better, if possible, to give a fixed prosthesis or fixed treatment to that kind of patients if they can afford. Then classification of partially edentulous arches. So before going to classification, first we discuss why we need that. So just to formulate a good treatment plan, to communicate with the professional about a case, like to communicate with the dental lab. Let's say if we are having a class Kennedy class 1 case, and we want to tell the lab guy, so just that we are that we I want him to plan a treatment for me for a class 1 case. Then how will he understand if he also knows that class 1 is this, and class 2 is this, and class 3 is this, and class 4 is this? So it is very easy for me and for him to make him understand, and for him to understand what I am saying and what I want. So it is better to have a classification. It is very it will make very easy communication, very easy with the professionals, between the professionals also. So, and to get an idea of existing dentition, then the requirements of the classification, so it should be simple and universally accepted. So, why universally accepted? Let's say I am a dentist who is based in India, and I want to send my work somewhere in, let's say, UK or US. So to make that guy who is in US, if the classification which I am using or I am following is universally accepted, so it is very easy for me and for him to understand. If the classification is universally accepted, if the classification is not universally accepted, then it is very difficult for me to make him understand, and for him also to understand what I want for this particular case. Then it also allows us to visualize what type of partially dentulous arch is, and that is being considered. And it allows differentiation between tooth supported and tissue supported partial dentures, and it should give an idea of type of design to be used. It should be easy to remember and cover almost all situations. Then there is a scientist named Kennedy, whose name is Dr. Edward Kennedy of New York. In 1925, he gave a most popular classification which we routinely follow in our clinics or in our colleges. So first one is the class 1. So just to remember, class 1 means there are two posterior edentulous spaces. Fine. So now, what is class 1? So class 1 is bilateral edentulous areas located posterior to the remaining natural teeth. Simple. Then what is class 2? Just I have discussed opposite. When there is class 2, there is only single unilateral edentulous area located posterior to the remaining natural teeth. Then class 3. Class 3 is unilateral edentulous area with natural teeth present anterior and posterior to it. Then class 4. Class 4 is a single bilateral edentulous area located anterior to remaining natural teeth which crosses the midline. Then there are two Applegate modifications which is given by Applegate in 1960. So basically Applegate modified Kennedy class 3 into two types depending on the type of abutment. Like if we can take support of the abutment, then it will be class 5. And if we cannot, if we don't want if we cannot take the support from the abutment, it is class 5. If we can take support, then it will be considered in class 6. So two modifications are there, class 5 and class 6. Now let's see what is class 5. So class 5 is unilateral edentulous areas with natural teeth anterior and posterior to it, in which the anterior abutment teeth is not suitable for support. Example, lateral incisor. We do not consider lateral incisor as a good abutment teeth. Why we do not consider it a good abutment teeth? Because the root length is smaller as compared to the other teeth, and it is also the clinical crown height is also less. So we not consider it as a good abutment teeth. So if a class 3 condition presents and the anterior abutment teeth is little incisor, then we consider this as a class 6, a class 5, Kennedy class 5. Then for class 6, edentulous area in which the teeth adjacent to the space are capable of total support of the required prosthesis. Then it will be considered as the class 6, which is the modification, which is the modification given by Applegate. Then Applegate also given like 8 rules. So let's see it one by one. So first rule is classification should follow rather than precede extractions that might alter the original classification. The second rule is if the third molar is missing and not to be replaced, it is not considered in the classification. And if the third molar is present and is to be used as an abutment, it is considered in the classification. Then fourth rule is if the second molar is missing and not to be replaced, it is not considered in the classification. The most posterior edentulous areas always determine the classification. Edentulous area other than those determining the classification are referred to as modification spaces and are determined by their number. The extent of modification is not considered, but only the number of additional edentulous areas that is considered. And class 4 has no modification. Why class 4 has no modifications? Because uh, if a posterior teeth is missing, and as the Applegate says that if a posterior teeth is missing, it will consider that in the classification. So that's why class 4 has no modifications. Fine. So in a condition like, let's say, if a 3 if a 3 6 is missing and also 3 1 and 3 2 is missing, so it will not be considered as class 4 mod 1. It will be considered as class 3 mod 1 because class 4 has no modifications. And also we have to consider the posterior dental space for the classification. Then there is another classification which was Osborne and Lemmy classification, which was given in 1974. It is the class 1 is mucosa bone, class 2 is tooth bone, class 3 is combination of mucosa and tooth bone. And the other classifications are also there, like commerce classification, which is based on the position of the direct retainers, which was given in 1921, then Bellins in 1928, then Ferdinand neurons in 1939, then Edwin H. Mock in 1941, R.J. Godfrey 1951, Beckett 1953, then Friedman's 1953, Skinner's 1957, William Evans 1969, Austin Leach 1957, Swenson's 1955, Costa's 1974. So there are many classification, but what we usually follow is Kennedy's classification because it is easy to understand. Then the components of partial removal dentures are major connector, minor connector, rest, direct retainer, indirect retainer, denture base, and artificial teeth. So let us discuss one by one. Here you can see one diagram. We'll discuss this diagram later on. Fine. So first is the major connector. So major connector is that part of a removal partial denture process that joins the components on one side of the arch to those on the opposite side. What are the requirements of major connector? So it must be rigid, must provide vertical support and protect the soft tissues, must provide means of obtaining indirect retention where indicated, must provide an opportunity of positioning denture bases where needed, must maintain patient's comfort. Then there are types of major connector. So we are having separate major connectors for separate arches. Like for maxillary, there are almost 6 major connectors. For mandibular, there are 4 major connectors. So what are they? So first, let's take a look for maxillary major connectors. So first one is single posterior palatal bar. So as the name suggests, there is only a single bar-like thing which is placed posteriorly on the palate. So this is the, like, as you can see in the name. So this is single posterior palatal bar. Then just we broaden this, so it will be called as palatal strap. The second one is palatal strap. Then third one is anteroposterior or double palatal bar. Then the fourth one is horseshoe shaped connector. Then closed horseshoe or anteroposterior palatal strap. Then sixth is complete palate. Then mandibular major connectors. First is lingual bar. Second is lingual plate. Lingual plate, lingual plate major connector can be used where the anterior teeth are periodontally compromised. So just to support them, we can use this lingual plate major connector. Then double lingual bar or Kennedy bar. Then labial bar. Then minor connectors. So minor connectors is the connecting link between the major connector or base of a partial removal dental prosthesis and the other units of the prosthesis such as clasp assembly, indirect retainer, occlusal rest or cingulum rest. And the types of minor connectors are joining the connector which joins the clasp assembly to the major connector, which joins the indirect retainer or auxiliary rest to the major connector, which joins the denture base to the major connector, or as approach arm for a vertical projection or bar type clasp. Then first one, as we have seen, join the first minor connector is the connector which joins the clasp assembly to the major connector. Second is which joins the indirect retainer to the auxiliary rest of the major connector to the major connector. Then third is the which joins the denture base to the major connector, and last one is the uh, approach arm for a vertical projection or bar type clasp. Then rest and rest state. So rest is defined as a rigid stabilizing extension of a fixed or removable partial dentures with which contacts a remaining tooth or teeth to dissipate vertical or horizontal forces. Rest seat is the prepared recess and a tooth or restoration created to receive the occlusal, incisal, cingulum or lingual rest. Type of rest are occlusal rest, cingulum rest and incisal rest. As the name suggests, occlusal rest will be present on the occlusal surface of the posterior teeth in molars or premolars. Cingulum rest will be present mostly on the canines, on the cingulum area, and incisal rest will be present on the incisors. Then direct retainers. So it is that component of a partial removal dental prosthesis used to retain and prevent dislodgement consisting of a clasp assembly or precision attachment. So basically direct retainers are divided into two types, intracoronal and extracoronal. And direct retainers are also called clasps, which we use to make the removal partial denture retained. Retention of the which we use for the retention of the removal partial dentures. So intracoronal ones are precision attachment, internal attachments, and prefabricated attachments. And extracoronal ones are manufactured retainers, example Dalbo. And custom made retainers are crucially approaching clasps and gingivally approaching clasps. Then components of a clasp. So basically, clasp is having 7 components. So basically, a clasp is having 2 arms. One is retentive arm and one is reciprocal arm. So in retentive arm also there is the tip is called is retentive terminal, then the retentive clasp arm, then reciprocal arm, then occlusal. Fourth is the occlusal rest. Fifth is the shoulder. Sixth is the body, and seven is the part which is called minor connector, because minor connector will join this clasp assembly to the major connector. Then type of clasp. So circumferential clasp, also called occlusal approaching clasp, and suprabulge or Eckers. So now we'll see one by one. So first is simple circulate clasp, reverse circulate clasp, multiple circulate clasp, embrasure clasp, ring clasp, face hook, hairpin clasp, only clasp, grasshopper clasp. And the next one is vertical projection clasp or gingivally approaching clasp or infrabulge or Roche clasp. So basically, what is the difference? What is the basic difference between these two clasps? Is that this circumferential clasp will approach gingiva. Will sorry will so this circumferential clasp is will circumferentially cover the abutment tooth, and it will approach from the occlusal surface. That is why it is called occlusal approaching clasp. And this vertical projection clasp is basically it will approach from the gingival and to the occlusal surface. Like in the infra, this is also called infrabulge because it engages the um, lower one third, like cervical one third of the tooth. And the type of clasp are T class, modified T class, Y class, and I class. Now let's look at the picture one by one. So this one is the simple circulate class which we routinely use. Second is the reverse circulate class. Third is the multiple circulate class. Fourth is the embrasure class. Then fifth is the ring clasp. Six is the fish hook or hairpin clasp. Seven is the only clasp, and eight is the grasshopper or VRHR clasp. Then vertical projection clasps are first is the T clasp. Then one arm is removed, so it has become modified T clasp. Then there is Y clasp and then I clasp. Then indirect retainers. So it is the component of a partial removal dental prosthesis that assists the direct retainers in preventing displacement of the distal extension denture base by functioning through lever actions on the opposite side of the fulcrum line when the denture base moves away from the tissues in pure rotation around the fulcrum line. So types of indirect retainers are auxiliary occlusal rest, canine extension from the occlusal rest, canine rest, linguoplates, rugae, and indirect retention from major connectors. Then denture base. So basically the part of a denture that rests on the oral mucosa and to which the teeth are attached. Types of denture bases are first is acrylic, second is metal, and third is combination. Then artificial teeth. So types of teeth are acrylic teeth, porcelain teeth, tube teeth, reinforced teeth. Just to discuss lightly, why not whole metal or whole acrylic, or why not? So basically, the idea behind is we want to reduce the acrylic part at the same time, not whole metal, because if we want to in any case we want to reline it, or we want to like reduce the denture base. So if the denture base is made up of metal, so it will be very difficult for us to reline it or reduce it. So half part, like the metal framework is made up, like the framework is made up of metal, and the part we want to reline or like adjust is made up of acrylic. So it will be very beneficial and it will be very helpful for a dentist, and also it is very beneficial for the patient as well. And the cost factor will also increase if we make whole metal. It is not recommended. Then artificial teeth. So types of teeth are the teeth we can use are first is the acrylic one, second is the porcelain, third is tube teeth, and fourth is reinforced acrylic phonetics. So most common teeth we use in our removal partial denture treatments are acrylic teeth because they are easy to, like, their cost factor is also considered here, and they are readily available. They are not costly. Uh, Easy acceptability by the patient. So there are many advantages of this acrylic teeth. Then let's discuss this picture. Uh, so here you can see I have numbered this. I have numbered this, and let's see one by one. Number one is a major connector. This is a mandibular class 2 modification 1 condition. Fine. So here I have given lingual par major connector. Second one are these are the minor connectors which are connecting the different parts of cast partial denture to the major connector. Here as you can see rest is connected by major connector with the help of this minor connector, uh, and so on. Then third is the occlusal rest. Then fourth is the direct retainer. Fifth is the reciprocal arm. Thank you. Have a nice day.